Good morning, everyone. So it is my great pleasure this morning to introduce Dr. Aanika Balaji to you. I have to keep telling myself to call her doctor instead of just Aanika. So I met Aanika when she was a freshman here back in 2014. She took one of my classes, and then from taking that class, joined my lab. And she worked in my lab all through her college education, but during that time, most students come and they do the project that you have in the lab, but Aanika didn't do that. Aanika came and made 3 different proposals, all of which were funded, to do the research that she wanted. So Aanika was a microbiology major, and she was determined to do something that was appropriate for her microbiology degree. So she did projects in the lab that joined together microbiology techniques with cancer biology, because she's also always been very interested in oncology. One of those projects was her ability to go to Sweden and work in a collaborator's lab, which she also did a fantastic job in. And all through her time in my lab, she was a great contributor, intelligent, hardworking, compassionate, all the things that you want to see in somebody who's going to go forward and become a physician. And then when she got into Johns Hopkins, we were all very excited for her because we knew that this was a great path for her to go out and spread all these great qualities and into the world and take them out and be this compassionate, intelligent, thoughtful physician that she has turned into now that she is doing her residency in internal medicine and going on to be an oncologist. And with that, I will welcome Aanika up to the stage to tell you about what she's been doing.
Okay, thank you so much, Joyce, for that really kind introduction. Starting off in your lab really did set off all of my interest in my research, and I definitely still want to be an oncologist, so thank you for giving me my start. So today, I would like to talk about immune checkpoint inhibitors, which are a relatively new class of drug that have completely revolutionized oncology care. So today what we'll do, I'll give you a little intro about me so we get to know each other better. And then we'll do a little bit of immunology 101 so we can understand how these drugs work. We'll talk about the drugs, and then we'll talk about what happens when they don't work as well. And then I'd like to end my talk just a little bit of more information about my Bravo trip. Okay, so my story starts in New Zealand, actually. So I was born there. My parents completed medical school in India and then spent some time in New Zealand, and I came along. And after our stay there, we moved to Chicago, Illinois, where my parents completed residency at the University of Chicago, and I was just a kid. So then we moved to Missouri. We were actually near Lake of the Ozarks, and I actually feel like people know where this is now. People had no idea where Ozarks were, and that is thanks to this show. But my childhood was nothing like that. When I was 9, moved to Arizona, where I claim is my home. So we moved to Mesa, Arizona. Here's a picture of our backyard in East Mesa. That's my best friend, Raquel. And I went to Westwood High School. Go Warriors. Any other Westwood alum, please come find me later. There's me getting my license, graduation, and then I was very excited to come down to Tucson and do some science here. First picture here is in Dr. Fodor's lab. I think this is part of my yeast 2 hybrid, but I was studying the interaction between EGFR and MUC1 in triple-negative breast cancer, and it was a very fun time in the lab. And then, of course, have a pic from Zona Zoo my freshman year, had a great time, going to all the games. So then after, I moved to Maryland. I went to Johns Hopkins for medical school. Here's some pictures from that time. So first picture is after my first board exam. So we take 3 board exams, step 1, 2, and 3. I did not look nearly as happy finishing step 2 or 3. I was just exhausted. Middle picture is from my MPH graduation. So after a third year of med school, I stepped away and took a year to do an MPH at Hopkins as well. This was during the COVID pandemic, so everything's virtual by the end of the year. And then lastly is med school graduation time. I was thrilled to have matched at Johns Hopkins for internal medicine. And middle picture is the day before I started working as a doctor. Very scary times, I didn't feel ready. And then by the end of that first year, me in pink scrubs, was the last day of my intern year. So I finished a whole year being a doctor and had learned a lot along the way. Okay, so switching gears here, this is a very cool picture of the immune cells attacking a cancer cell. So you can see here, these pink T cells have all worked together and are now killing off this very large cancer cell. So to understand how this happens, let's understand a little bit about immunology. So we have the T cell, and we have a B cell, our antigen-presenting cell. So basically what happens is the B cell, or dendritic cell in some cases, presents kind of foreign material to the T cell. And when a T cell recognizes this material, it engages. And it requires two different signals to actually perform an action. So it's kind of a confirmatory check, or like a two-factor authentication. So when that happens, the T cell is able to release some enzymes that then go on to kill foreign material. So that could be viruses, it could be tumor cells. Essentially, it does a fantastic job at its job. So there needs to be a way to stop the action once it's started, and that those are through the immune checkpoints. So I kind of think of this kind of like a gas pedal and a brake. So this is our brake. There are many different immune checkpoints. These are some of the best studied, the CTLA-4 and then PD-1, PD-L1 pathways. So when these are engaged, the immune cell stops releasing enzymes and then goes back into circulation looking for a signal to be reactivated. So cancer cells are very smart. They've been able to learn about this and present different immune checkpoint inhibitors on their own surfaces. And a very common one is PD-L1. So tumor cells are able to stop immune cell action even before it's performed. So in the last 15, 20 years, there have been developments to stop the brake. So these are immune checkpoint inhibitors. They're all antibody-based drugs. And like I said, there's many different immune checkpoints. These are some of the most commonly used drugs that we have. We have CTLA blocking with ipilimumab. We have nivolumab and then durvalumab, which also inhibit different checkpoints. And this is very exciting. These are some of the really important papers from the clinical trials that ended up getting these specific drugs FDA approved. So these are just 4. I could have put it up here a lot more, but ipilimumab was actually the first FDA approved drug, and it was used in metastatic melanoma. So I'm gonna pull a figure from one of these papers. It's from the nivolumab trial, just to kind of illustrate how well these drugs work. So this is a waterfall plot. And basically, each bar is a patient's journey through the trial. And we're looking at the change in their tumor size across the trial. So more negative is better. So the nivolumab arm is on the top. And you can see that a lot of patients, more than half, responded. And a lot of them had a complete response, or at least more than 50% response in reduction of tumor size. So this is a standard of care chemotherapy. There are less people here, of course, but proportionally, they didn't respond as well, and they didn't respond with nearly as much tumor reduction. So immune checkpoint inhibitors have been in the news for a little while now, and they actually, the scientists whose work led to these drugs being created won the Nobel Prize in 2018. So Dr. Allison discovered the CTLA-4 pathway, and then Dr. Hanjo's work led to PD-1 inhibition as well. So in practice, these drugs are being used all the time, is what I want to show you. So this is first-line therapy. So basically what that means is if a patient comes to an oncologist's office and has advanced cancer, these types of cancers, the first drug we'd reach for is an immune checkpoint inhibitor. Even 5 years ago, this is not the case. So please don't remember any of this. The only thing that I want to emphasize is There's a lot of these drugs being used as first line. If I wanted to even show you the second and third line therapies, I couldn't fit it on this slide. We'd probably just be naming drugs for the rest of the time. And there are hundreds of ongoing clinical trials. So these drugs are really being used and being further studied for cancer care. So I've said a lot of great things about these drugs. They've done a fantastic job with enhanced tumor killing. Unfortunately, the other hand is they do advanced cellular killing as well. So they can affect the body and have off-target effects, which is a bit of a plot twist. So these are immune-related adverse events. Basically, like I said, off-target effects of the immune checkpoint inhibitors. And they can affect any organ in the body. So can cause inflammation leading to some devastating side effects. I've included a few organs here, but I think of note, pneumonitis and then colitis are quite common. When patients develop myocarditis, inflammation of the heart, it can be really devastating. And unfortunately, patients have passed away from immune-related adverse events. So one of the first studies that I did at Hopkins was just kind of surveying the landscape of immune checkpoint inhibitors and IRAEs. So over 6 months, we looked at all the admissions to Johns Hopkins Hospital, and there are 443 total patients. Then we saw how many of them had immune checkpoint inhibitors as part of their regimen. It was 100, and how many of those folks had IRAEs? 23. So what sort of IRAEs were we seeing? Like I said, most commonly, we were seeing pneumonitis, saw colitis, hepatitis, also pretty commonly. And there's a large category of other, meaning that patients came in with a wide spectrum of these IRAEs. And I think some, to point out that were a little more interesting, were the hypophysitis, so that's inflammation of the pituitary gland and can cause a lot of endocrine problems down the line. And then myasthenia gravis is a neuromuscular disorder that's antibody mediated. So it's quite interesting that patients can develop that as well with this drug. So we grade the severity of IRAEs. There is a branch of the FDA that has kind of laid out many tables with specific characteristics for each IRAE, but in general, grade 1 is mild, grade 5 is death, and then in between, grade 2 is moderate, meaning that the patient is affected by this IRAE, but they only require non-systemic treatment. So usually an example would be if they had dermatitis, then you can give topical steroids. Grade 3, it requires hospitalization, and oftentimes patients are treated with steroids, usually oral prednisone. Grade 4 is life-threatening, so it requires an ICU admission, and then is treated with IV steroids. So in our study, we didn't have any grade 1s, which makes sense because I was looking at inpatient admissions. We had 8 grade 2s, meaning that patients were admitted for a different reason. We found out that they had an IRAE, then we treated that IRAE as well. 10 folks had grade 3, 2 people had to go to the ICU, had grade 4 events, and unfortunately 3 people passed away. One other tidbit that we were looking at was risk factors for increasing someone's likelihood of being admitted for an IRAE. So we had a smaller study, so some of these differences that weren't statistically significant may have been if we had more patients. But in our study, we found that if patients had more than one immune checkpoint inhibitor as part of their regimen, and if they were older than 65 years old, they had increased risk of admission compared to folks who had just one immune checkpoint inhibitor, and if they were younger than 65. And I do want to let you know that this is a huge area of research, and there aren't actually established risk factors. There are things that we see trend towards an increased risk of IRAEs, but there's nothing that, we don't have a definitive list of them because different studies have shown different things. And now that we have really good immunosuppressants, we are able to even sometimes prevent IRAEs from happening. Okay, so it talks about treatment a tiny bit. So when we have an IRAE, first thing we usually go for is steroids, prednisone. And then the next step, if patients aren't responding to prednisone or steroids, is additional immunosuppression. That becomes a little more nebulous as to what to choose next. So these are just some immunosuppressant drugs. They work in different ways, and they've all been studied for steroid refractory immune checkpoint or steroid refractory IRAEs. So one of the studies we did was looking at patients who had pneumonitis and were steroid refractory, and trying to see if we used IVIG versus infliximab, who had better outcomes. So I'll be showing you guys CT scans. I just want everyone to be on the same page here. In our first picture, identify normal lung tissue, nice, black, airspace. The green circle shows airways. The red circle shows vasculature. This is all normal. And then the second picture is lung bases. So you can start to see other organs pop into view, the liver, spleen, stomach. And then in the first picture, the middle organ is the heart. But you already knew that, so that's why I didn't say it. Okay, so in our study, we, like I said, looked at IVIG and infliximab, and then some patients got both. So this is before patients were even treated with immune checkpoint inhibitors, their baseline scan. Their lungs look really nice here, pretty clean. Patient 3, you can actually see their lung cancer right here. And this is when they got pneumonitis. And you can see the drastic changes. Pretty much we don't have those clean lung air spaces anymore. We start to see consolidations, traction bronchiectasis, ground glass opacities, all fancy words to say inflammation of the lung. And then this was after they got additional immunosuppression. So recall they've already had steroids at this point in time, and then they got either IVIG, infliximab, or both. And patient 3 had a really nice resolution of that inflammation. So did patient 8. Patient 10's scans didn't look markedly better, but clinically this person improved, so we took that as a win. Okay, and these are patients who didn't improve with the exact same regimens, exact same type of cancers, and exact same type of IRAE. So beforehand, this is our baseline scan. Patient 9 kind of already had some lung changes, as you can see. This is when they got pneumonitis. The red circles show kind of areas of interest. And then after additional immunosuppression, unfortunately, all 3 of these patients had worsening lung findings, worsening inflammation, and that's what these blue circles are showing. So ultimately, we didn't really find the answer to which is the next best drug to reach for. I think it's patient-specific as to who will respond and who will respond to what. So this still also remains an area of interest for research. So the future of immune checkpoint inhibitors, there's a lot more research to come. This is a really cool exploding field. So like I had mentioned, immune checkpoint inhibitors are used in multiple cancers. So we're seeing more and more patients being given this treatment. Therefore, we will likely see more and more IRAEs. So very important for inpatient doctors and oncologists to recognize these side effects. Another area of interest is biomarkers. So both looking at who might respond to immune checkpoint inhibitors and who is susceptible to IRAEs before, trying to predict who might be susceptible. We now also have specialists who study IRAEs. So at Hopkins, one example is we have a cardiologist who sees all of the myocarditis patients secondary to ICIs and really has made a lot of contributions to research about how to treat these patients compared to, let's say, viral-induced myocarditis. And then also something to think about is with immune checkpoint inhibitors, patients are living longer and longer, which is amazing. So now we are learning about what needs survivors have with chronic cancers and then also chronic IRAEs. An example would be type 1 diabetes. Patients can develop that after immune checkpoint inhibition, and that now becomes something that patients have to deal with moving forward. Okay. Oops. Well, I will tell you about BRAVO. So Biology Research Abroad Vistas Open. This arrow is pointing at nothing yet, but I did go to Gothenburg, Sweden. This was in the summer of 2015, and I worked in Dr. Gunnar Hansen's lab, and he's a mucin biology expert. And mucins are basically a class of proteins. Like I'd mentioned earlier, Dr. Schroeder's lab was studying MUC1, and Dr. Hansen's lab studied kind of all the mucins, but MUC2 in particular. Some pictures from my trip. The top picture is from the middle of the city in Gothenburg, so really pretty place, very green. Loved being there in the summer. There was 20 hours of light during the day. It was really fun. Still very cold for an Arizonan, though. I didn't go with a jacket and had to buy basically a whole new wardrobe. Bottom picture is my walk into the University of Gothenburg every day. A really pretty place. Okay, so just to give you guys a little bit of information about mucins. So mucins are proteins that have carbohydrates attached to them, oligoproteins. So the backbone is protein, and then you can see these little branches that come off. Those are carbohydrates. And MUC2 in particular is important for forming mucus. So we have a picture of a small intestine here. The peaks are called villi, and the valleys are called crypts. In the crypts, there are stem cells that then differentiate as they move out. And the mucus is important because it not only protects the cells from shear stress, it also protects them from bacteria and other critters that might want to attack the small intestine. One cell in particular that's important is the goblet cell because this cell creates the mucus. So a clinical correlate is cystic fibrosis. You may have heard of this disease, and normally you think of lung problems. Essentially, these patients end up having very thick mucus and have a hard time clearing mucus, therefore have a lot of lung infections, but also have a lot of GI problems as well since their mucus isn't as thin and isn't able to be cleared as easily. So my project was looking at MUC2 release from organoids, and basically, organoids are little tiny organs. It's very cool. We were able to take stem cells from mice and then grow them in a 3D matrix. And they form these little balls where the inside kind of represents the small intestine lumen. And we had wild-type mice and then mice who had cystic fibrosis. And all of these mice had RFP-tagged MUC2, so it was easy to see where the MUC2 was going, how it was moving. So we stimulated these cells to release their MUC2 and then looked at the size, the shape, and the red fluorescent signal as well. So what we ended up finding was that these cystic fibrosis organoids didn't end up growing much in size when they were stimulated. They also had much more concentrated red fluorescent signaling, which makes sense with the biology that we already know. And we were able to confirm these findings by also doing a tissue culture, and I was able to learn about confocal imaging as well, so that was really cool. The first picture is from the mouse room at the University of Gothenburg. You actually had to change into this outfit. There were clogs included as well. Do an air shower before you went in, did your stuff, air shower on the way out, and then you were able to go do your research. So it took forever to get samples. And then the entire lab went to the UK in the middle of the summer for a mucin conference, and it was really fun to be able to put together my work, present it to experts in mucin biology, and really just learn from everybody there. It was really fun. I did do stuff outside of lab as well. So the first picture is from the central station in Gothenburg, and that was kind of the main train station you can use to travel around Sweden. And I did take some trips. The city of Gothenburg is actually part of an archipelago, so there's a lot of bridges that connect the little islands to the main part of the city. And this particular spot was one of my favorites to watch the sunset. It was near my house. And then the bottom picture is a hike that was near my house as well. And again, just really gorgeous, and had a great time exploring the city. Made some friends, so there were some other people from out of the country working near me. So we had a lab tech and then two au pairs who I had met, and we spent the summer together. We went on a little trip together for midsummer, and as you can see, we're wearing our flower crowns, as you do in Sweden. And then at the end of the summer, we all took a road trip up north again to a different seaside town, and it was just a lovely time to be able to make these connections and make my own community there. Okay, and the picture of the castle is from our trip earlier during the midsummer trip. I tend to forget that there's just castles dotting Europe, so really cool. You can just kind of drive up, go explore, see some history. And then this tram picture is one of the special trams that actually takes you to Gothenburg's amusement park called Liseberg. But the tram system is really pretty, and it works so well there in Gothenburg. That's how to get around the city. So there's me having won the big chocolate at Liseberg, which was definitely a summer goal. Glad that I could do that. And then the sunset pictures the last day before I left Sweden. Really pretty. It was just a really nice way to end the trip and leave on a really good note. So some parting thoughts for y'all. So I wouldn't be an Osler resident without quoting father of internal medicine, Sir William Osler. I really like this quote. So live neither in the past nor in the future, but let each day's work absorb your entire energies and satisfy your widest ambition. And to me, it's really important and resonates with me because I'm always looking toward the next step. I feel like in different parts of my career, it was when I was an undergrad, I was looking at med school, and med school was looking at residency, and it's really important to stop, take a break, and enjoy the moment that you're in and the step that you're in. So I just want everyone to be reminded of that too. And I also want everyone to know that the work you're doing now is unbelievably important, not only for yourself and your career, but you're advancing science. You really are. This is an awesome university. There's a lot of awesome opportunities here, and you're already taking advantage of one of them being in UBRP. So take as much as you can and learn as much as you can during your time here. It goes by so fast. I was in your seats 7 years ago. I can't believe I'm here. So just a reminder to recognize the importance of your work. So a lot of people to thank. Definitely thank you so much, Dr. Schroeder, again, for giving me my first taste of science. Dr. Bender and Jennifer, really appreciate all of your help and support throughout the journey of UBRP. Some of my mentors from Hopkins, Dr. Naidu, Dr. Clever, and Dr. Suresh. I couldn't be here without my family, my friends, my cat Blue. You all should feel free to contact me, ask me any questions, medicine-related, research-related, whatever. I'm here to answer. I am on social media, but I don't really use it that much, but happy to connect in any way that's easiest for you. So thank you so much for your patience and your attention. Had a great time being here.
Thank you so much. I appreciate it. So we'll have a little bit of time for Q&A. And so I'd like to ask if anyone has a question. Quinn and I will run around with a microphone.
Hi, hello. My question is, were you always set on going to like microbiology and medicine? Was that always just a path you were destined to follow?
I was always interested in science. So when I came to U of A, I was kind of mostly choosing between a career in research versus in medicine. My parents are both doctors, so I did have a lot of just medicine in my life and could see what that was like. So long answer short is yes. I was mostly interested in kind of picking a career within science.
I'm just curious, how did you identify your opportunity for the Bravo summer experience, and maybe any things you took away from that were unique from other parts of your education? How did it change the way you approach your work or your life?
Yeah. So Bravo, I identified this opportunity because you had to pick a lab that works with your home lab. So Dr. Schroeder had a couple collaborators in different countries, and Sweden sounded like a great place to visit, and also the biology is very interesting. So ended up contacting Dr. Hansen, and with him, we wrote a proposal for the summer of the work that I would be doing there. And in terms of just finding Bravo in general, it was something that one of my classmates had done the year prior and really loved the experience. So as soon as I heard about it, I definitely knew I wanted to apply. And in terms of lessons that I learned, I think for me the biggest takeaway outside of science in Gothenburg was learning to form my own community and learning to kind of establish myself. Like I said, I went there, I didn't know anybody. I was so lost. I lived next to a cemetery, and I got lost in that cemetery so many times. So I'm glad the sunset wasn't until like 1 a.m. because it was very creepy at times. But that was important because when I moved to Baltimore, again, I didn't know anybody, and I was really nervous, and I kind of felt like a fish out of water. This place I've only heard about in movies and books. So it was weird to actually be there, but it was awesome to be able to establish my own community there as well.
So I was just wondering, I'm a physiology and nutrition major, so I was wondering if like in any of your research you ever looked at like how like diet impacted like patient outcomes, especially with like things like anti-inflammatory nutrients, like with the IRAEs you were mentioning, or if that's being looked at all. I was just curious.
Yeah, actually, what another kind of arm of very interesting research that's happening is looking at the microbiome and seeing how that affects patients who have IRAEs. So there's actually a database at Hopkins that collects samples from patients before they're treated, during treatment, and once they get an IRAE. And then scientists are looking at what kind of cytokines can be found in their blood and their other samples. So that's one area that's definitely being looked into. In terms of diet itself, that isn't something that I'm super aware of, but I know that it's probably being studied.
I just had a question about how Bravo impacted your career. Do you feel like it was helped you move forward into medical school very well, or was it the things that you did before then that helped your application the most?
Bravo was incredible, and I'm so glad I was able to do it. I think one thing to like kind of scientifically was that you were able to make connections abroad, and I still was able to maintain those connections when I came back here. In terms of just catching up with the lab, seeing what they were doing, and they were very interested in what I was doing as well, so it was a nice connection in that sense. But other than being able to form my own community, I also gained a lot of confidence. I mean, I'm very shy at heart and kind of introverted, and I was forced to not be. And I think that was important. I became a lot more sure of myself, I feel like, by the end of that trip.
Hi. I guess I was just wondering, like, looking back, is there anything that you would do differently, or like, is there anything you'd recommend for us to do in our undergrad?
To do what afterward?
Hmm?
Is this just like in general, or?
Yeah, just in general, like looking back, like on your life, like anything that you'd like want to experience more that you think would help us out, or just yeah.
I mean, I think that's a little bit of a hard question to answer, but I think what I wish I would have done differently is I've always wanted to learn a second language, and I wish that I did a major in something outside of science as well, in addition to science, just to kind of almost force me to take some of the classes that you need. So that was one thing. The other thing is I went straight through from undergrad to med school, and in hindsight, I do wish I took some time for myself. And I'm glad I did the MPH, because I feel like that was when I was able to do that. But I did feel like I was just kind of I was on a treadmill. I was just going on this treadmill, and I needed a break at one point in time or the other. And I think a little bit earlier could have been nice, and it would have given me some more life experiences.
If you were to go back to undergrad, would you do MD PhD rather than MD?
Yeah, that's a great question. So MD, PhD, a little bit longer route. Your schooling's paid for, and then it gives you the tools to run your own lab after you complete your training. So I think for me, I'm not someone who sees myself running a lab. I think doing clinical research and being part of a research group is definitely in my future. So I don't think I would do a PhD personally, but I think I may have enjoyed doing some research years before having gone to med school.
Can I ask if you have like a favorite research technique or favorite like project that you've worked on in your time, and just like talk about it?
Yeah, so I did present one of them, the steroid refractory pneumonitis project, and the reason why I liked it so much is that was a project where I actually could take it from inception to completion and actually did everything. So I made the database. By that point in time, had my MPH, so I knew how to analyze data. So I was able to create all the figures. I was able to analyze and actually find the conclusions, and then writing the paper as well. So it felt like a really nice culmination of all the skills that I'd gained throughout med school and before then as well. And currently also I'm working on a collaboration with neurologists, and we're doing a survey of neuro-IRAEs, which has been very interesting to learn about. So that's also been a fun project.
I think Carol's going to have the last question.
So, did your research experience as an undergraduate help you in medical school relative to your colleagues who didn't have a research experience? And if so, how?
Definitely, definitely. I think early on, something that I felt like I could do better was just even absorb the literature and understand what I was reading. And I felt very comfortable going back to primary literature if I had questions about what I was learning. And then I think it also helped me in the sense that I knew what I was interested in. And I had a great mentor, so I knew what I was looking for when I was looking for a great mentor. So all of these skills that, maybe I didn't think about when I applied to UBRP have been very, very helpful moving forward. I ended up not doing basic science research in medical school and beyond, but it was really good to be able to understand what was happening in the lab and how that was important in translating to the clinic.
Okay, one more.
How did you become so self-aware? Noticing the meta skills that are so important for being successful in life. Appreciating that. You want to comment on that?
Well, it all started back when. I think that having to grow as a leader in different roles has made me more self-aware, and I think especially this year. This year compared to all of the years of my life, I'm now what is called a senior resident. So it's funny because you end intern year and you're still an intern, and then the next day they expect you to lead a team. So the last month I've been on a rotation where I've been leading a team, and I have interns who I work with, and it's been really important to remain calm when things are going on, to be there to answer the questions and to guide folks toward making the right medical decisions. But in doing all of that, I'm learning so much about myself, about how others learn, and I think just in general about being the leader and being the commanding voice in the room. And I think something that I definitely do want to comment on is that being a woman in medicine, times have changed, and times are changing in the sense that there has been a notion in the past that perhaps women's opinions weren't as heard as loudly as others, and that's definitely changing, but it is really important to be confident in your decisions and speak loudly and be able to command a room. So that's something that I've learned throughout residency.
Right, I think on that note, it's a perfect note, then we want to say thank you for coming today. We really appreciate it. Thank you.
Thank you so much.